Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 401 of our pharmacotherapy series, which majors in upper gastrointestinal disorders. The next clinical case reads: LTF is a 48-year-old woman who presents to her primary care provider complaining of recurrent heartburn occurring daily for the past 6 weeks. She states that the heartburn occurs frequently after meals and often wakens her at night. Lately, she has been experiencing difficulty swallowing solid foods. LTF currently smokes 2 packs of cigarettes per day and likes to have 2 glasses of wine each night with her dinner. She states that she occasionally uses over-the-counter ranitidine 150 mg orally up to twice daily, which temporarily relieves her symptoms. So my first question to you reads: what diagnostic modalities are available for the evaluation of her gastroesophageal reflux disease, abbreviated as GERD? Let's first discuss clinical assessment and diagnosis. Numerous diagnostic options exist for the evaluation of the patient with presumed gastroesophageal reflux disease. The medical history should include the identification of specific symptoms and an assessment of symptom frequency, severity, and duration, as well as risk factors or triggers. An empiric diagnosis can be made in the majority of patients based on the symptoms of heartburn and regurgitation. However, patients who present with severe symptoms, alarm symptoms, or long-standing gastroesophageal reflux disease, or who do not respond to empiric therapy, warrant further diagnostic evaluation. Next, we will consider acid suppression empiric test. A trial of a proton pump inhibitor is commonly used to empirically diagnose typical gastroesophageal reflux disease-like symptoms in patients without alarm symptoms or symptoms of complicated disease. Doses used in clinical trials range from 20 to 80 mg of omeprazole, or equivalent, once daily for up to 4 weeks. If symptoms are relieved after a short trial of a proton pump inhibitor, that is 7 to 14 days, an empiric diagnosis of gastroesophageal reflux disease may be made and other invasive and costly diagnostic methods may be avoided. However, this methodology is not without its limitations. The test cannot differentiate between other acid-related disorders, such as peptic ulcer disease, and studies evaluating its ability to detect gastroesophageal reflux disease versus other diagnostic options have been equivocal. Despite these shortcomings, guidelines suggest that an empiric trial of a proton pump inhibitor is appropriate in selected patients given its ease of use and reduced cost. The empiric use of a proton pump inhibitor may also be beneficial in identifying patients with extraesophageal manifestations of gastroesophageal reflux disease. Further diagnostic evaluation is warranted in patients who do not respond to acid-suppressive therapy, who present with alarm symptoms or symptoms suggestive of complicated disease, or who have long-standing gastroesophageal reflux disease where the possibility of Barrett esophagus exists. Next we will look at upper endoscopy and biopsy. Upper endoscopy is the primary diagnostic method for evaluating the esophageal mucosa for injury or cellular changes. This test is highly specific, yet only moderately sensitive for the diagnosis of gastroesophageal reflux disease, because many patients present with non-erosive disease. There are 4 primary reasons why endoscopy is performed in patients suspected of having gastroesophageal reflux disease. A. To rule out significant disease, e.g., adenocarcinoma of the esophagus, or complications, e.g., stricture. B. To screen for Barrett metaplasia. C. To evaluate and grade the severity of esophagitis. And D. To allow the provider to optimize treatment and predict the long-term course of the disease. The endoscope can be fitted with surgical instruments to allow the operator to perform procedures or obtain tissue specimens for biopsy. Endoscopic grading of the esophagus is based on the level of inflammation and mucosal damage. 2 endoscopic classification systems are used for the grading of esophagitis. The Savary-Miller classification categorizes patients from grade 0 to grade 4 based on the severity of mucosal erosions of the esophagus. The addition of a grade 5 was added to include the diagnosis of Barrett esophagus. Although this classification system is no longer recommended in the United States, it is still used in many practices, as well as in Europe. The Los Angeles classification is preferred because it is more specific and categorizes patients from grades A to D based on the number of mucosal breaks, their size, and the amount of surface area with esophagitis involvement. There is no classification for normal esophagus with this system, and symptomatic patients are often classified with non-erosive reflux disease, abbreviated as NERD. Biopsy of the esophageal mucosa is performed during endoscopy, and tissue samples are evaluated by microscopy for evidence of Barrett metaplasia or neoplastic disease. In patients with suspected Barrett metaplasia, the biopsy is obtained after the esophagus has healed to prevent misinterpretation of the inflammatory markers for dysplastic syndrome. Mucosal biopsy for inflammatory markers in non-erosive disease remains debatable. Let's now consider 24-hour continuous ambulatory pH monitoring. Ambulatory pH monitoring is a valuable diagnostic test for evaluating gastroesophageal reflux disease. It is especially helpful in patients who have not responded adequately to reasonable pharmacotherapy, in patients with non-erosive disease, and when there is a need to correlate reflux events with symptoms. A small, that is 2 to 3 mm diameter, pH electrode is threaded through the patient's nostril, similar to placing a nasogastric tube, past the patient's larynx, to approximately 5 cm above the lower esophageal sphincter in the distal esophagus. Once it is connected to a logging device, which documents pH measurements every few seconds, it allows for the determination of reflux events, defined as esophageal pH below 4, duration of reflux events, and percentage of time within a 24-hour period that the patient's pH is less than 4. The patient is asked to keep a diary to record symptomatic events that can be correlated with a decrease in esophageal pH. This is especially important when correlating extraesophageal manifestations with reflux events. Let's now look at radiologic testing. The barium esophagram, barium swallow, is used primarily to identify suspected esophageal abnormalities, such as strictures, narrowing, and hiatal hernia, and to determine peristalsis disorders. The procedure is relatively non-invasive and inexpensive when compared with endoscopy. Next we will consider esophageal manometry. Esophageal manometry is used to evaluate the patient's lower esophageal sphincter pressure and esophageal peristalsis. This procedure does not have a specific role in the diagnosis of gastroesophageal reflux disease, because it does not detect the presence of acid within the esophagus. It is used primarily to evaluate patients before 24-hour continuous ambulatory pH monitoring and anti-reflux surgical procedures, e.g., Nissen fundoplication, to determine the location of the lower esophageal sphincter. LTF's frequent severe symptoms continue despite over-the-counter ranitidine 150 mg orally twice daily, and the presence of warning signs warranted that she undergo endoscopy, which revealed moderate esophagitis, Los Angeles grade C, the presence of an esophageal stricture, and no evidence of Barrett metaplasia. Esophageal dilation was performed during the procedure to widen the lumen of the esophagus. So my next question to you reads: what treatment options exist for LTF? Let's discuss the pharmacotherapy beginning with antacids. Antacids are useful only in the relief of mild symptoms associated with gastroesophageal reflux disease. Because of their short duration of action and inability to heal erosive esophagitis, they are not an option for treating moderate to severe gastroesophageal reflux disease. Next we will look at histamine 2 receptor antagonists. Histamine 2 receptor antagonists are effective in treating patients with mild to moderate gastroesophageal reflux disease, but response rates vary with the severity of disease, the dose of the drug, and the duration of therapy. Histamine 2 receptor antagonists are considered equally effective when used in equipotent doses for symptomatic relief and esophageal healing. They are effective in reducing nocturnal symptoms, but only modestly effective in relieving meal-related symptoms, because they only block one mechanism of parietal cell activation via the H2 receptor. Histamine 2 receptor antagonists relieve symptoms in about 50% to 60% of patients treated after 12 weeks of continuous therapy and are superior to placebo. Increasing the histamine 2 receptor antagonist dose may not improve symptoms in some patients. Esophageal healing requires higher doses, e.g., famotidine 40 mg twice daily, compared with those used for symptom relief. Esophageal healing rates with histamine 2 receptor antagonists are reported to be about 50% after 8 to 12 weeks of treatment, but rates will vary depending on the degree of esophagitis. For example, endoscopic healing rates in trials with high-dose histamine 2 receptor antagonists were approximately 60% to 90% in patients with grades 1 and 2 esophagitis, but were only 30% to 50% in patients with more severe disease, grades 3 and 4 esophagitis. Some investigators have attributed inadequate esophageal healing to the development of tachyphylaxis. Next we will discuss proton pump inhibitors. Proton pump inhibitors are the drugs of choice for patients with frequent moderate to severe gastroesophageal reflux disease symptoms and esophagitis because they provide more rapid relief of symptoms and esophageal healing than do histamine 2 receptor antagonists. When used in recommended dosages, all of the proton pump inhibitors provide similar rates of symptom relief and esophageal healing. Their superior efficacy, when compared with histamine 2 receptor antagonists, is related to their ability to maintain an intragastric pH less than 4 for a long duration time, up to 24 hours per day versus up to 10 hours with a histamine 2 receptor antagonist. Typically, proton pump inhibitors are taken once daily 30 to 60 minutes before breakfast, but if a second dose is required, it should be taken before the evening meal. A large meta-analysis of 16 trials confirms that proton pump inhibitors are superior to histamine 2 receptor antagonists for achieving rapid and complete relief of gastroesophageal reflux disease symptoms. Complete symptom relief, within 4 to 12 weeks, was achieved in 77.4% of patients taking a proton pump inhibitor versus 47.6% of those taking an histamine 2 receptor antagonist, with a p-value less than 0.0001. Proton pump inhibitors have also been shown to heal esophagitis more quickly and effectively than histamine 2 receptor antagonists. In the same meta-analysis, which evaluated 43 double-blinded or single-blinded, randomized studies, including patients with severe esophagitis, proton pump inhibitors, that is 83.6%, were more effective than histamine 2 receptor antagonists, that is 51.9%, at healing erosive esophagitis at 12 weeks. Healing also occurred more quickly with proton pump inhibitor therapy in that by week 2, 63.4% of patients had healed with the proton pump inhibitor, whereas it took 12 weeks with the histamine 2 receptor antagonists for 60.2% of patients to heal. Another large meta-analysis, which evaluated more than 33 randomized trials, demonstrated similar results with 81.7% of patients healed at 8 weeks with a proton pump inhibitor versus 52.0% with an histamine 2 receptor antagonist. Esophageal healing among proton pump inhibitors appears to be equivalent, because about 85% to 90% of patients achieve complete healing at 8 weeks in numerous head-to-head trials with equivalent doses. One meta-analysis, which compared esophageal healing rates among omeprazole 20 mg, lansoprazole 30 mg, pantoprazole 40 mg, and rabeprazole 20 mg, each given once daily, reported no statistical difference. However, all of the proton pump inhibitors were superior to ranitidine 300 to 600 mg per day. Esomeprazole 40 mg once daily has been reported to be superior to omeprazole 20 mg once daily, at both 4 and 8 weeks, when used to heal erosive esophagitis. However, the esomeprazole 40 mg and omeprazole 20 mg dosages are not equipotent, and this study has been heavily criticized based on this fact. Another study, which compared equipotent doses of esomeprazole, dosed at 40 mg, and lansoprazole, dosed at 30 mg, also suggests that esomeprazole has statistically significant greater healing rates, that is 92.6% versus 88.8%, respectively, with a p-value equal to 0.0001. In contrast, a similar study comparing lansoprazole 30 mg with esomeprazole 40 mg showed no statistical difference in esophageal healing, albeit with a smaller population. Dexlansoprazole MR 60 mg once daily has been compared with lansoprazole 30 mg once daily in randomized, double-blind clinical trials to assess healing of erosive esophagitis. The results using life table analysis reveal similar healing rates with dexlansoprazole MR 60 mg and lansoprazole 30 mg, 92% to 93% versus 86% to 92%, respectively. But the results were not statistically significant. A higher dose of dexlansoprazole MR, dosed at 90 mg daily, was superior to lansoprazole, dosed at 30 mg daily, in patients with more severe disease, i.e. Los Angeles classification grades C and D, but these are not equipotent doses. In spite of the lack of supportive evidence, some clinicians prefer to use esomeprazole 40 mg per day or dexlansoprazole MR 60 mg per day for patients with severe erosive esophagitis. The ability of a high-dose proton pump inhibitor to reverse Barrett metaplasia remains controversial. Although studies have demonstrated islands of normal squamous epithelium returning, no data have determined that this is associated with a risk reduction in adenocarcinoma. In fact, others have suggested that this return of normal mucosa may actually mask carcinogenic changes occurring deeper in the gastric mucosa. Improvement in quality of life has also been evaluated in patients receiving proton pump inhibitor therapy in the management of gastroesophageal reflux disease. A recent study comparing esomeprazole with ranitidine during a period of 6 months showed a significant improvement in both physical functioning and sleep with the proton pump inhibitor therapy. Let's now shift gears to prokinetic agents. 2 prokinetic agents, metoclopramide and bethane chol, may be effective in the management of gastroesophageal reflux disease. Both drugs increase lower esophageal sphincter pressure and stimulate the motility of the upper gastrointestinal tract without altering gastric acid secretion. Although these drugs may provide relief of symptoms, they are ineffective in healing erosive esophagitis unless they are combined with an histamine 2 receptor antagonist or proton pump inhibitor. Prokinetics are not widely used to treat gastroesophageal reflux disease, because they are not as effective as other treatments and are associated with numerous side effects, sedation, anxiety, extrapyramidal symptoms, etc. Prokinetics are reserved for patients who are refractory to other available treatment options or who have delayed gastric emptying. Let's now briefly look at sucralfate. Sucralfate appears to be effective in treating mild cases of gastroesophageal reflux disease and possibly mild esophagitis, but is not effective in the management of severe disease. Given more effective options at this time, sucralfate is rarely used in the management of gastroesophageal reflux disease. Proton pump inhibitors are considered the drugs of choice for patients with frequent or severe gastroesophageal reflux disease symptoms, or who have complicated disease, because of their potent inhibition of gastric acid secretion. In this case, LTF, who presents with severe esophagitis, Los Angeles grade C, will require a PPI taken once daily in order to relieve her symptoms and heal the esophagus. A reasonable option for LTF would be lansoprazole 30 mg daily to be taken 30 to 60 minutes before breakfast each morning for the next 8 weeks. However, if the cost of therapy is an issue, generic omeprazole 40 mg daily would also be an acceptable alternative. LTF should also be counseled regarding lifestyle and dietary modifications, including smoking cessation and abstinence from alcohol. She should avoid eating large meals before bedtime and may wish to elevate the head of her bed by 6 to 8 inches with wooden blocks. LTF's symptoms resolved in about 2 weeks after starting proton pump inhibitor therapy, and she remained asymptomatic after 8 weeks. She then underwent endoscopy again, which revealed that the esophagus had healed completely. Her primary care physician then stopped the proton pump inhibitor. Now, 2 weeks later, she is experiencing mild heartburn. My next question to you reads: is LTF a candidate for long-term maintenance therapy? Gastroesophageal reflux disease is a chronic disease. Up to 80% of patients with severe esophagitis and 15% to 30% with less severe disease have a symptomatic relapse within 6 months after discontinuing treatment. The goal of maintenance therapy is to keep the patient symptom-free and prevent potentially life-threatening complications. Continuous maintenance therapy with a daily proton pump inhibitor is more effective than a histamine 2 receptor antagonist, with reported relapse rates of 25% and 50%, respectively. Thus, proton pump inhibitors are the drugs of choice for maintaining remission in patients with healed esophagitis. A histamine 2 receptor antagonist may be considered for patients with mild non-erosive disease. Although 1/2 of the proton pump inhibitor dose used for esophageal healing has been suggested, guidelines indicate that the recommended maintenance dose should be the dose that is required to render the patient asymptomatic. Maintenance therapy, to reduce the risk of morbidity associated with chronic, relapsing disease, should be initiated with lansoprazole 15 to 30 mg once daily or equivalent proton pump inhibitor dose, given the severity of LTF's esophagitis and symptomatic recurrence after discontinuing the proton pump inhibitor. We will now briefly look at on-demand pharmacotherapy. The use of intermittent, that is on-demand, courses of proton pump inhibitor therapy, that is for 2 to 4 weeks, has been suggested as being potentially beneficial in patients with gastroesophageal reflux disease. One trial, which compared continuous maintenance therapy with esomeprazole 20 mg daily versus on-demand therapy with the same drug and dose in patients with healed erosive esophagitis, reported that continuous therapy was superior to on-demand therapy, that is 81% versus 58%, respectively, in maintaining endoscopic remission at 6 months. The ability to maintain remission with on-demand therapy was reduced as the severity in esophagitis increased. Although numerous studies with a variety of proton pump inhibitors have demonstrated patient satisfaction with on-demand therapy, a systemic review of 17 trials evaluating the use of on-demand therapy indicates that intermittent therapy should only be considered in patients with mild, non-erosive disease. Let's now progress to combination of a proton pump inhibitor and histamine 2 receptor antagonists. The addition of a histamine 2 receptor antagonist at bedtime to a once or twice daily proton pump inhibitor regimen is sometimes used for patients who continue to have nocturnal symptoms, although the evidence to support this combination remains inconclusive and current guidelines do not endorse this type of anti-secretory management strategy at this time. The rationale for this practice is based on an evidence that suggests a period of nocturnal acid breakthrough, defined as intragastric pH below 4 for longer than 1 hour during the night, in a significant number of patients despite twice-daily proton pump inhibitor therapy. suggesting that histamine release may have an important function in nocturnal acid secretion. One study suggests that the addition of a histamine 2 receptor antagonist to a twice-daily proton pump inhibitor regimen resulted in a statistically significant reduction in nocturnal acid breakthrough during the sleeping hours. This trial, however, evaluated only a single bedtime dose of a histamine 2 receptor antagonist and did not consider the tachyphylaxis that can occur with continuous use. A subsequent trial using a twice-daily proton pump inhibitor regimen with continuous use of a histamine 2 receptor antagonist for 4 weeks demonstrated no difference in nocturnal acid suppression, suggesting that tolerance does play an important role in the use of histamine 2 receptor antagonists for this indication. It has been theorized that one way to possibly avoid this occurrence is to use the histamine 2 receptor antagonist on only an as-needed basis when lifestyle and dietary modifications are not effective for preventing nocturnal symptoms. We will now consider non-erosive reflux disease. Up to 75% patients with typical gastroesophageal reflux disease symptoms who undergo endoscopy will not have evidence of esophagitis or complicated disease. These patients are described as having functional heartburn, non-erosive reflux disease abbreviated as NERD, or endoscopy negative reflux disease abbreviated as ENRD, and often undergo 24-hour ambulatory pH monitoring to determine whether abnormal reflux is present despite a negative endoscopy. A trial of a proton pump inhibitor is usually indicated despite no esophageal findings, because many patients will respond to this therapy. Further medical evaluation is required if a patient does not respond to proton pump inhibitor therapy despite a doubling of the daily dose. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 402.